This case study is on a widowed 40-year-old African-American male, EW. He has an appointment today with his primary care provider and his annual physical examination to renew his blood pressure medication. He states that he has had trouble regulating his hypertension lately, with difficulty over the last year or so, and hypertension in his life for the last 11 years. He states that he has gained 20 pounds in the last year, and according to his current height and weight, his BMI is 31, which would make him obese. He states that he has a poor diet in which he admits to salting food before tasting it and does not watch his fat or carbohydrate intake. He also has no formal exercise program. EW has many stressors in his life. His current occupation is that of air traffic controller, which is considered to be one of the most stressful jobs in the world, requiring total concentration. He has been widowed from his wife for the last 5 years after she committed suicide. His son, thereafter, approximately a year later, he became estranged from, which could be surmised as a catalyst in their relationship due to the death of his wife a year earlier. He takes minimal medications with hydrochlorothiazide at 50 milligrams daily, Sudafed as needed, the beclomethasone nasal spray as needed, and Tylenol as needed. His current lab values for his cholesterol are out of normal range. Total cholesterol is 275, which is above the threshold of 200. His HDL is decreased to 31, which is out of the protective norm, normally wanted in the 45 to 50 range if possible. His LDL is elevated at 179, and his triglycerides are elevated at 290. He admits to recurrent sinus infections and shortness of breath with minimal exertion. His family history, genetically, is his father and mother both had hypertension, and his mother has diabetes as well. His father died of an acute myocardial infarction at the age of 49. Hypertension is a disease that evolves slowly due to multifactorial issues. It is defined as a systolic blood pressure of 130 or greater, or a diastolic pressure of 80 or greater. Genetics plays a significant role in hypertension, and while there is ongoing analysis and genomic research in its infancy, there have been several genes identified with the increased risk of hypertension. There is a correlation in comorbidities such as diabetes and hypertension, which are often seen in conjunction due to the insulin resistance. Another large component to hypertension is an individual's lifestyle choices and environmental factors, such as smoking, poor diet, and lack of exercise, which contribute to these cellular changes. The lifestyle choices and factors increase adipose tissue, which is in turn the cause of a cascade of cellular events. Adipose tissue, specifically white adipose tissue, enhances the production of inflammatory factors through the secretion of adipokines. Adipokines contribute to the initiation and progression of obesity-induced metabolic changes. When white adipose tissue is stored viscerally, which is the case in obesity, its effects are increases in insulin resistance, altered lipid metabolism, and chronic inflammation, a decrease in renal sodium excretion, and abnormal activation of the SNS and RAAS systems, which contribute to the changes in vascular and blood volume control. The blood flow can also be impeded through vasoconstriction due to inflammation in the vessel walls caused by circulating enzymes and hormones. When the SNS is activated, it increases heart rate and peripheral resistance. It increases insulin resistance and vascular remodeling, in addition to proagulant effects, which in turn create endothelial dysfunction and vessels which narrow. Overactivity of the SNS can also be the result of the increase in catecholamines, which raise the heart rate as well. Dysfunctional activation of the RAAS system creates the activation of AT1 receptors, and they in turn cause systemic vasoconstriction and water renal salt retention, inflammation, insulin resistance, and remodeling of blood vessels. With the dysfunctional vasoconstrictive hormone release and angiotensin II, there become structural changes in remodeling, which result in a permanent increase in vascular resistance peripherally. The increase in naturopathic peptides, which are vasodilators and typically regulate sodium and water excretion, they become released by the increases in blood pressure and cardiac volume, and it becomes a catch-22 where the pressure increases and more peptides and hormones are released. The resistance in blood flow through those peripheral volumes and increase in the total cardiac output, which is what eventually causes the hypertension. As you can see in this graph, the genetic influences and environmental factors work in many ways. As they're combined, the following events occur. The obesity increases white adipose tissue, which releases adipokines, and insulin resistance causes vasoconstriction, leading to increased peripheral resistance and vascular remodeling. The dysfunction of the SNS and RAS, along with the naturopathic peptides, cause renal salt and water retention, leading to an increased blood volume and increased cardiac output. When either the increased circulating volume or cardiac output is increased, hypertension occurs. Early hypertension has no manifestations, and thus hypertension is known as a silent disease. The signs and symptoms of hypertension are usually found by a trained professional checking the blood pressure in conjunction with those other organ systems that are affected by the increase in pressure. EW's blood pressure was 155/96, which places him in the stage 2 hypertension category according to the new guidelines. The retention of water and salt leads to edema in some people in their peripheral limbs, and it also increases the shortness of breath and work of breathing due to the vascular remodeling and vasoconstriction. There is a decreased immunity that's involved with his chronic sinus infections due to the dysfunction of inflammatory effects and circulation of enzymes and hormones abnormally. At least 65 million Americans, or 1 in 4, are active in the hypertensive category, and another 1 in 4 are in the prehypertensive, or now considered elevated category, which is defined as a systolic blood pressure of 120 to 129 millimeters of mercury, or a diastolic blood pressure of less than 80. The deaths reported for 2016 were 33,246. These deaths were only self-reported through clinical guidelines, and there could be many, many more that actually died of hypertensive diseases. But typically, hypertension is not considered a cause for death. What is cause for death is the stroke or MI or other renal failure problems that occur, which then create the failure of the body systems to continue to operate correctly. In the years 2013 through 2016, the Centers for Disease Control incidents are those age-adjusted and those over 20 years old, that white persons typically have hypertension about 29.2% of the population, with males just slightly higher in that, within that 29% of 31% of that total. African American or black persons are much increased with a hypertension of 42.2%, with males showing a slightly higher percentage within that as well. And so we can see that the burden of hypertensive disease is higher by a significant amount in races other than white. It indicates that the percentage of those with hypertension increases as the individual lives closer to the poverty level as well. This data suggests that the cheaper and more readily available foods, which are rich in fat, sodium, and carbohydrates, add to the environmental factors discussed earlier, which raise the risk of hypertension, as well as the inability to exercise or have a regimented exercise routine. This chart is included to show the newest blood pressure guidelines from the American Heart Association, American Stroke Association, which have changed over the last year with decreases in the systolic and diastolic numbers to reflect the importance of keeping hypertension down and blood pressure down in order to minimize disease states.
Risk factors for hypertension include age, EW is 40 years old, ethnicity, African Americans develop hypertension more than any other racial background in the United States, a family history of hypertension, and we know that EW's father and mother have either had or currently have hypertension, genetic factors, lower education and socioeconomic status, which influence diet and lifestyle patterns, tobacco use, EW has had 10 years of cigarette smoking in his history, psychosocial stressors, which include the death of his wife by suicide, the fact that he is an air traffic controller, and the fact that he is estranged from his son, sleep apnea, dietary factors, which are very important. They include high fat intake, high sodium intake, lower potassium intake, and excessive alcohol intake, which is referenced by his nightly beer consumption and his history of ETOH, glucose intolerance, and while EW does not have diabetes, based on his weight, we can infer that he likely has glucose intolerance, no regimented exercise, and obesity. He did have a 20-pound weight gain in the last year. Hypertension can definitely be managed by lifestyle modifications, and that should be the first line of therapy when dealing with hypertension. With improved diet, increased exercise, and smoking cessation, hypertension can be prevented, managed, or even reversed. The DASH diet is a tool recommended by healthcare providers and utilized by patients. It stands for Dietary Approaches to Stop Hypertension. And this diet includes 3 parts. The first would be eating more fruits, vegetables, whole grains, and nuts. Second part is eating less fat, sodium, sugary drinks, red meat, and processed foods. And the last and third part is eating moderate amounts of low-fat dairy products. This diet is generally effective in lowering blood pressure. And according to our textbook, here's a direct quote, physical training increases stroke volume, which has the effect of lowering heart rate and hence systolic blood pressure, and should consist of regular aerobic physical activity. Exercise is definitely important in managing or preventing hypertension. And lastly, smoking cessation lowers blood pressure, of course, because we are stopping those vasoconstrictive effects of nicotine. But if lifestyle modifications are not enough, or if individuals are not compliant with lifestyle modification recommendations, pharmacologic intervention may be warranted. Again, according to our textbook, common medications to lower blood pressure include thiazide diuretics, ACE inhibitors or ARBs, and calcium channel blockers. And of course, the individual's other comorbidities will influence which medications they should be using. These medications generally work by decreasing preload and or decreasing afterload, and sometimes, of course, more than one medication is necessary to achieve a target blood pressure. Because of the numerous interventions out there to prevent, manage, or reverse hypertension, the condition really is by no means expected to be morbid. If you have hypertension but manage your blood pressure appropriately, the expected outcome is that you live an otherwise normal and healthy life. It is really when your blood pressures remain elevated or uncontrolled that you can expect problems. And As we have been discussing throughout this case study, uncontrolled hypertension negatively influences all other body systems, which really promotes poor outcomes and comorbidities. These comorbidities include but not limited to renal insufficiency, CHF, coronary artery disease, peripheral vascular disease, retinopathy, aneurysms, TIAs or strokes, sexual dysfunction, and the list goes on. For individuals who do not adequately manage their hypertension, these are the complications that we can expect to be part of the disease course over the long term. And in terms of prospect of recovery, many individuals can't completely reverse hypertension if it's diet or lifestyle related, and they make serious changes to their lifestyle. If there is a genetic component to the hypertension, or if it cannot be completely reversed for whatever other reason, blood pressures can still be appropriately managed at the very least, utilizing diet and lifestyle modifications in conjunction with pharmacologic agents. Given the extensive treatments for hypertension available today, there is no excuse for sustained elevated or uncontrolled blood pressures and its subsequent complications, so long as the individual adheres to prescribed medications and closely monitors his or her blood pressures accordingly. Why is the patient taking hydrochlorothiazide, and what is the primary pharmacologic mechanism of action of the drug? Hydrochlorothiazide is a thiazide diuretic. Thiazide diuretics are the first line of choice diuretics used to treat uncomplicated hypertension. This drug lowers blood pressure by two mechanisms. The first is that it decreases blood volume via diuresis. This drug inhibits distal convoluted tubule sodium and chloride resorption. And this is the initial antihypertensive effect. The second effect is that it decreases arterial resistance, which is long-term. What is the most clinically significant information related to hypertension in this review of systems? The most clinically significant information related to hypertension in the review of systems is the patient's shortness of breath with activity and that his breathing difficulties are getting worse. And these new symptoms indicate a decline in the patient's status. Additionally, a new onset of shortness of breath may be caused by hypertension in the pulmonary vasculature. This is called pulmonary hypertension. Our textbook explains that shortness of breath with exertion is a common symptom of pulmonary hypertension. Regardless of the cause, though, of this new symptom, shortness of breath can lead to an entire new set of problems and comorbidities for the patient if left untreated. Are there any abnormal neurologic findings, and if so, might they be caused by hypertension? There are no abnormal neurologic findings based on this patient's physical exam. However, any presence of abnormal neurologic findings could absolutely be caused by hypertension, as the brain is also a target organ affected by uncontrolled blood pressures. Mechanisms of brain injury as a result of hypertension include reduced blood flow and oxygen supply, weakened vessel walls, and accelerated atherosclerosis. According to the textbook, the consequent pathologic effects may include TIAs, cerebral thrombosis, aneurysm, hemorrhage, or acute brain infarction. Patients with hypertension who experience neurological involvement often experience headaches and decreased alertness as two prominent and discernible symptoms. What is the clinical significance of the single abnormal urinalysis finding? The single abnormal urinalysis finding for EW is positive microalbuminuria. According to an article published in the medical journal Hippocratia, microalbuminuria, which is defined as urinary albumin excretion of 30 to 300 milligrams a day, is an early sign of vascular damage. While microalbuminuria can indicate kidney involvement in diabetes, it is also closely related to abnormal blood pressure. The article has a significant quote, and it reads, "Even high normal blood pressure is associated with significant higher frequency of microalbuminuria, and in this way may be a biomarker of increased cardiovascular risk. Microalbuminuria could be taken also as an indicator of insulin resistance and of the increased renal and cardiovascular risk associated with metabolic syndrome." End quote. Microalbuminuria is clinically significant because it further highlights the severity of EW's uncontrolled hypertension and how it is beginning to affect other target organs. According to our textbook, the mechanism of kidney injury caused by sustained hypertension is reduced blood flow, increased arteriolar pressure, RAAS and SNS stimulation, and inflammation. The resulting pathologic effects include glomerular sclerosis, decreased glomerular filtration, and kidney disease, hence the microalbuminuria. EW's uncontrolled hypertension is causing renal insufficiency, putting him at greater risk for cardiovascular events and/or renal disease and the subsequent complications of these pathologies. What is the likely pathophysiological mechanism for LVH in this patient? With sustained increased blood pressures in the vessels, the heart must pump against more resistance than normal to maintain adequate perfusion to the rest of the body. The left ventricle specifically is more affected by elevated blood pressure than the other chambers of the heart, since this is the one chamber responsible for pumping blood throughout the entire systemic circulation. Simply put, under hypertensive conditions, the left ventricle must work harder. But the heart is a muscle, no different than the biceps or quadriceps, and like all muscles trained against greater resistance, it will hypertrophy when challenged with overcoming elevated blood pressures. Consequently, left ventricular hypertrophy, LVH, is a common manifestation of hypertension.
EW had the following diagnostic and laboratory tests performed: laboratory blood tests, urinalysis, electrocardiogram, and echocardiogram. Laboratory blood tests are necessary tests that can reveal pertinent information regarding a patient's body's physiological response and current state, as well as identifying diseases the patient may be at risk for. Some current abnormal results from EW's lab work include an elevated bicarb of 27. This could possibly be explained to his use of thiazides from a process called contraction alkalosis, which is just an increase in blood pH as a result from the fluid loss from diuretics. An elevated ALT of 43 and GTT of 119. These could indicate some degree of liver disease or injury that could be attributed to his chronic alcohol use of several beers every evening, coupled with his common use of over-the-counter extra-strength acetaminophen. And also his elevated total cholesterol of 275, LDL of 179, and triglycerides of 290. This tells us the patient has hyperlipidemia, probably due to his poor eating and lack of exercise. The hyperlipidemia puts this patient at increased risk of having and developing coronary artery disease or myocardial ischemia from atherosclerosis. The urinalysis is an easy laboratory test to be able to tell how a patient's kidneys are functioning. The point of this test for this patient is because hypertension can cause renal failure. His urinalysis was positive for microalbuminuria. A typical sign of early renal injury is macro or microalbuminuria. EW's urinalysis was positive for micro. This is an important identifier as the kidneys are a target organ affected by hypertension. The microalbuminuria can be caused from direct injury to the glomerulus from chronic hypertension. Injured glomeruli can progress to glomerulosclerosis, which is permanent scarring of the vessels in the glomeruli, causing end-stage renal disease. So again, it's important to find this early to take preventative actions. The electrocardiogram is able to tell us heart rate and rhythm, including any abnormalities due to a patient's life, electrolytes, drugs, or disease state. The echocardiogram is able to determine the heart's function and efficiency by detecting its cardiac output, ejection fraction, as well as the current structure. The ECG and echo both show EW has moderate left ventricular hypertrophy, which is due to increased demand and workload on the left ventricle. This hypertrophy is the left ventricle becoming thicker, thus weakened, stiffer, and less elastic, contributing to his ejection fraction of 46%. The following education regarding the disease and management would be given to the patient and his family. So hypertension, also known as high blood pressure, is when there is a consistent elevation of pressure pumping through the arteries, which are the blood vessels that carry blood away from your heart to the rest of your body. Ideally, your blood pressure should be under 120/80. Yours, however, has been averaging 155/96. The first number is called systolic pressure, which is the measure of pressure in your arteries as your heart beats. The second number is called diastolic pressure and is a measure of the pressure in the arteries as the heart relaxes. The increase in pressure causes the heart to work harder to pump blood. Hypertension is a complex disorder that affects the entire cardiovascular system. All stages of hypertension are associated with increased risk for organ damage, such as heart attacks, kidney disease, and stroke. Some factors that influence your chance of developing hypertension are genetic and modifiable factors like diet, exercise, and smoking. Some things you can't change are things like race, gender, age, and family history. Being an African American male puts you at higher risk of developing hypertension than others. The main goal now would be to keep it under control with diet, exercise, and adherence to a medication regimen in order to prevent any future health risks. There are primary, secondary, and tertiary interventions you can do to manage your high blood pressure. Some primary interventions would be to eat a healthy diet and maintain a healthy lifestyle. The DASH diet is a dietary approach to stop hypertension. This diet should be low in salt or sodium, preferably less than 1,500 milligrams a day, added sugar, and fat. Eating whole grains, fresh fruits and vegetables, low-fat dairy, and lean proteins are the best foods you could eat, as well as limiting your intake of alcohol to no more than 2 drinks per day. Lowering your body weight and becoming more active are great ways to improve your health and lower your blood pressure by getting at least 30 minutes of exercise 3 days a week, as well as remaining abstinent from tobacco and nicotine products, as they can also contribute to hypertension and other diseases too. A type of secondary intervention you can do is monitoring your blood pressure yourself. Regular monitoring of your blood pressure at home and reporting any significant difference to your healthcare provider can be beneficial to your health later on. Finally, as types of tertiary interventions, it's important for you to adhere to your medication regimen prescribed to you. Some common medications to control hypertension include diuretics, ACE inhibitors, ARBs, beta blockers, and calcium channel blockers. These drugs all act differently, but are used for the same reason, to lower your blood pressure. Follow your prescriptions carefully and exactly as prescribed to you. Do not skip any doses, as they could put you at risk for increasing your blood pressure and making the medicine less effective. Watch for and report any side effects to your provider so they could adjust your medications if necessary.